Hello and good afternoon. Here we are for our 10th episode of the Echoflix, a very, very special one again. And today we have a clinician. Unfortunately, it's not Dr. Michael Rigby. The case is from the Royal Brompton. It is his case, but he had a clinic, a last-minute clinic, and he will not be able to join. So I will be the clinician, but hopefully many other colleagues will join us here. And we'll have the heart surgeon to operate on the patient. Dr. Fernando Moraes, as we all know, and we have two morphologists, so hopefully the patients won't go directly to them, but that's great. As we know, all know very well here in Brazil, Vera Aiello, our great friend in morphologist that's always with us, helping and giving lectures and courses for us. And another very, very special person, another good friend, Dr. Siew Yen Ho, who is the head of the morphologist department at the Royal Brompton Hospital. So most of us have done the Brompton stage in our lives, and I realize that many Brazilians have been to the UK, and many Brazilians have trained in the United Kingdom at the Royal Brompton, and we all know Yen. So Yen, thank you very much for taking your time and being here with us today.
Oh, it's my pleasure.
Good, excellent. Okay, so as I said, the case is from Mike Rigby, and I will have to show them. Let me just share my screen. But as I understand, this is a boy who came in to do an echo with a diagnosis of a VSD. And then people went to do the echo. Let me just find out, how can I share the entire screen? Okay. I couldn't put them into a PowerPoint presentation. I apologize, but sharing the entire screen, I think, we'll be able to see the images. I'll have to take this one out, which is ours, and then, well, already the diagnosis, but I'm sure that most of you that have seen these images realized what it is. Tell me if it's not showing well or if I have any problems, okay? So I'll just get those images here. And the first image, as we see, is a subcostal view. We have the left atrium, the atrial septum, the right atrium, the tricuspid valve, the right ventricle, the right ventricular outflow tract here with pulmonary artery, and the aorta here at the center. This is one of the images that we have. Another image, which is subcostal as well, but that shows the left ventricular outflow tract. And we have the image here. And then you can see the VSD, we see the aortic valve, see the ascending aorta. I think we see a coronary artery here. Okay, so left atrium, left ventricle, and left ventricular outflow tract, a bit of the right ventricle anteriorly here. We have a 4-chamber view that shows, let me, again, put this up. We have Dr. Rigby's voice.
And when you've got a regular valve movement, you wouldn't actually know, would you?
Which is good. He's not here, but at least we have a little bit of his voice saying that it's a large left atrium, a large left ventricle. But as he says in the image, when you get a regular 4-chamber view, nothing calls much of your attention.
But when you've got a regular valve movement, you wouldn't actually know, would you?
Okay. So that's a 4-chamber view without much from the left heavy valve, from the mitral valve. Let me see what we have here. Another image here. Again, that's a subcostal view. We're getting a bit better of the tricuspid valve here. We see the mitral valve there, left ventricular outflow again with the coronary artery. And then we get onto the short axis views, which are the views where we see the lesion better. One thing that's important is in this short axis view, we have the papillary muscles, and it looks like that it's a normal valve with, a normal sub-valve apparatus with the papillary muscles. And once the image is shifted upwards, we have, oh God, where is the image? Which is the most important one. Yes, we have this image here, where you see the mitral valve, and you clearly see the two orifices of this mitral valve in the short axis view. Now, because this is a very rare lesion, and very important to be able to recognize this lesion, and then we can talk a little bit about the implications of what we are seeing here, which is a double orifice mitral valve. Ok? Gente, para quem está no grupo em português, a gente está fazendo isso meio a meio, né? Fala inglês, fala português e traduz, mas todo mundo acompanhando e vendo que trata-se de uma válvula mitral com dois orifícios, né? Um duplo orifício de válvula mitral. E é muito importante a presença aqui das nossas colegas patologistas para nos explicarem um pouco mais sobre isso. Depois a gente pode falar um pouquinho mais sobre a implicação clínica e chegar até a discussão do manuseio e potencialmente a cirurgia. Yen, I just, let me go back now to see myself. Okay, I'll stop screens. And I think we'll start with Dr. Ho, who will tell a little bit about the mitral valve and the normal morphology of the mitral valve, show a little bit of that. Then Dr. Aiello will comment and show us also a few interesting cases, and then we can open for discussion about management of this presentation and management of this children. Yen?
Okay, then.
That's just, yeah, I think your screen is coming right now.
Okay.
Good.
I'm going to, it's a short presentation, so I'm just going to show you some normal hearts first and orientate you. This is like looking down from the atrial chamber, so left atrium, right atrium. In the middle of the heart is the aorta, and we have the two leaflets of the mitral valve viewed from the atrial aspect. And this is a normal mitral valve. When we take the epicardial fat off on the outside, we should note the course of the left coronary artery, which can be dominant in about just under 10% of individuals. So in other words, if you are going to be intervening onto the mitral valve, we need to be aware of the various structures that are nearby. And the left coronary artery may be one of them. And this is a close-up view, again, the same orientation. This is the anterior leaflet. Some people call it the aortic leaflet on account of its position right next to the aorta. And the other one is termed the posterior leaflet or the mural leaflet. And when designating mitral prolapse, for example, these terms are used A1, A2, A3, or P1, P2, P3, kind of locations for the prolapse. And the asterisk just indicates the sort of cleft or kind of scalloping of this particular posterior leaflet. And of course, there are two commissures. If we look from the underside, we will see that the two leaflets supported by two groups of papillary muscles. They can be paired or multiple. They can even have multiple heads if it's a single papillary muscle, highly variable. So we see here cross-section through the ventricular mass, the septum, and a more or less circular appearance of the left ventricle. If we take a deeper cut, slightly deeper cut, we see the two leaflets of the mitral valve. This is the posterior or mural leaflet, and this is the anterior or the aortic leaflet. And these two ends would be the commissure, and you will note that each leaflet has attachments, chordae or caudal attachments to each of these two groups of papillary muscles. So it's very distinctive arrangement of a mitral valve. And taking a look at here in this region, we see the area of aortic and mitral fibrous continuity. In other words, there's no muscle separating aortic valve from mitral valve. And on this panel here on the right-hand side, we have a longitudinal cut through the left atrium, left ventricle, like an echocardiographic parasternal long axis view, for example. We see here the aortic valve leaflets in fibrous continuity with the mitral valve leaflets. And of course, in this normal heart, the leaflets are coming close together and forming a perfect closure line, in other words. But note that this white coloration is in fact the fibrous tissue sheath covering the atrioventricular conduction bundle, and here the left bundle branch. So just highlighting for you, in this particular area where the central fibrous body of the heart is, we will have the emergence of the atrioventricular conduction bundle. So again, another structure close to the mitral valve to be aware of. And over here, of course, across the atrioventricular junction, the epicardial fatty tissues colored up in sort of yellowish creamy color. We have the cardiac vein, the great vein, or the coronary sinus coming into the right atrium on the other side. And you might just pick up the left coronary artery in this particular heart, very small. Now, when you look through the literature about dual orifice or double orifice mitral valve, be a bit aware, because a lot of the examples we find are talking about this situation. For example, this one is partial atrioventricular septal defect, and this one a complete form of atrioventricular septal defect with two orifices or openings of the left side atrioventricular valve. But of course, we don't call this valve a mitral valve anymore. And in the case that you've seen on the echocardiograms, it's really a mitral valve. So an example of a dual orifice of the mitral valve, this is an example from our archive at the Brompton, opening up the left ventricle, and see a hole here, an orifice here, and another orifice here. Of course, the left ventricular wall cuts through. And this is the bridging tongue of leaflet tissue joining the anterior leaflet or aortic leaflet with a mural leaflet back here. And this is another view, but this time this particular part of the left ventricle has been deflected backwards. So we again see the two orifices funneling down into the left ventricular cavity, and here marks the attachment or the joining together of the leaflet tissue, between the two leaflets. And here, of course, the aortic outflow tract. And when looking from the underside, from the apex of the left ventricle, this is the kind of appearance you can get. But I might add on to say that the orifices can be very disproportionate in size. It really depends. In this case, this is more or less the kind of arrangement we are seeing. We see the two groups of peptic muscles, anterolateral and posterior medial here. Posterior medial has multiple heads, this sort of arrangement. So the bridging tongue of tissue may not be right in the middle, maybe more to one side, near to the commissure or the other commissure. And there have been descriptions about a circle of chordae tendini around these orifices. But I think this form is the more common form, if you like, even though dual orifice or double orifice, the mitral valve is extremely rare. But there are some reports describing duplication of the mitral orifice, or mitral valve. And this would be the kind of image that comes to mind. So each orifice has its own peptic muscle support, just like exactly a duplication of the mitral valve. But I think this particular configuration is far less common. I might be wrong. I'm sure Vera will tell me. So thank you for having me. Just to highlight that we do webinars and so on and so forth. And these are my coordinates if you need to get in touch with me. And I'm Yen Ho. Thank you.
Thank you so much. And great to see this. And yes, such a rare thing that I think many of us may not have seen or diagnosed. And very important also to comment on what is double orifice mitral valve and what is a valve that may have two orifices, but maybe in the setting of an atrioventricular septal defect, which may be a completely different entity.
Yes.
So yeah, that I think was very good. I think Vera has also a few images, and it would be very nice to look at them as well, and then perhaps we can discuss all together. Share your screen there.
First of all, it's a real pleasure to be here. I would like to thank Sandra for the kind invitation, and also it was very nice to meet virtually Yen Ho, who was one of my tutors when I trained at the Brompton, and she is very clear in everything she shows, and that was a privilege. This is a privilege to be here. Thank you, Yen, for coming. And I have some examples only. And as Dr. Ho said, this second, can you see my screen?
Mm-hmm. Yes, we can.
So, like Dr. Ho said, it's much more rare to have double apparatus, also double duplicated mitral valve. I don't have any example of this. So just to sum up, we may approach the congenital anomalies of the mitral valve as anomalies of the ring, the cusp, the tenuous cords of the subvalvular also apparatus. And so I also have the privilege of working with great morphologists from the nomenclature working group, that is Diane Spicer from the International Society of Nomenclature, and she also has very beautiful images. One of these images is this one I'm showing you, with a number one orifice here. The ventricular is open, and the second orifice, as Dr. Ho said, very much smaller than the other one. It's rare that both are have the same dimension. So here is the tongue of tissue. It looks like that there is I don't know, but it looks like that there is a muscular cord or muscular part of the papillary muscle joining together these two orifices. And this is from my collection of from the Heart Institute of São Paulo. And what I would like to show you is that I'm returning. In this case, it looks like there was no dysfunction, although dysfunction can only be defined by hemodynamics, but it looks like the valve itself is not very much disturbed because it's very thin, okay? But in this other case, from my collection, there was also a hypoplastic left heart. And you see here a very enlarged left atrium, a very thick mitral valve with two orifices of approximately of the same size. So in this context, the mitral valve was stenotic, I believe, because of the hypertrophic wall, or because of the consequences we are seeing here. Okay. And this is another specimen prepared by Diane Spicer, also showing a left AV valve. I'm not sure if this is a ostium primum or not, but there are two orifices seen from above, from the right atrium. And this is another example, and this time in a complete AV canal, or in the left component of the common AV valve. You see here the superior bridging leaflet, the inferior bridging leaflet, and here is the plane of the ventricular septum. And when you look inside the left ventricle, there is a second orifice. It's, as Dr. Ho said, it's not a mitral valve, but is left component of the common AV valve. In my opinion, it's much more frequent than the double orifice of the true mitral valve. I think Ian could comment on this also. And this is one specimen from also the INCOR collection. So this are the open left-sided chambers. The star marks an ostium primum defect. And here is the big orifice of the left component, and the second one is probed here, and is much smaller. And I believe this second orifice did not cause any dysfunction. Just to tell you that at the tricuspid valve, it can also be observed that this kind of tongue of tissue joining together here the septal leaflet and the anterior leaflet, and we are able to see the second orifice, and the large orifice is this one. So these are my cases, and I don't know if you want to discuss anything else. Let me stop sharing.
Good. Yes, it's the amazing cases, and so rare. I think the real importance is for people to understand that. I actually had a quick look at the disease itself, because I don't recall having seen. I'm not sure whether I've seen any of these cases, but anyway, I just put it over here because I thought it would be interesting to for us for the presentation. Apparently very rare. One annulus with two orifices. It has been described from the United Kingdom, a British pathologist, in 1876, from what I read. And please, Ian and Vera and Fernando, keep correcting me if I say anything which is not the case. And so basically, they also say that associations and defects such AVSD, which probably make it a different disease, as you have both pointed out. Some diseases of the left-sided arch may be associated. And then they describe these three types, which they call it the eccentric type, which is the more common, I guess. This is what we're talking. This central or bridge type may be, Ian, what you have mentioned, and you too, Vera, which is sometimes in the atrial septal defect, isn't it? And having the bridging leaflet. And then the very, very rare duplicate mitral valve type, when you really have the two complete things, orifices and subvalvular apparatus with papillary muscles and everything. There is a work from Boston Children's that says that in autopsy there, they saw it close to 1%. They identified a double orifice mitral valve, and in adults, about 0.6, but all from autopsy. And it was very interesting for both of you, Vera and Yen, to say whether you see this. From my feeling, it would be rarer than this. Not, I think this is a big yes, Yen.
I think the first paper there you cited, almost half of them were actually atrioventricular septal defects and not mitral valves, as we know them.
So that's probably what put that number up. Yeah, if you take the true double orifices, it would be much lower, and maybe even here as well, because when I was reading, I also noticed that they talked about post-operative double orifice mitral valves, which obviously would be the disease itself, but a consequence sometimes of the correction of some AV septal defects that could lead to that, to having the mitral valve with two leaflets. Again, would very much like to hear your insights into this. Do you see that chart goes to correct an atrioventricular septal defect and comes back with a mitral valve with two orifices? Is this something seen or common? I'm certain that Dr. Fernando Moraes will say that when he repairs a complete AV septal defect, the left AV valve will be left with one orifice and the right with one. Correct, Fernando? But anyway, reading the paper, they did say that sometimes in the post-op of a correction of an atrioventricular septal defect, sometimes you would see a double orifice mitral valve in that. Any comments on whether this is something
Do you mean acquired, like
yes.
as if the defect was not properly closed, or
yes.
if there was the sense of some jurors, and is that what you mean? Okay.
I think that's what the paper was mentioning, that when they were describing the double orifice mitral valves that they said. They mentioned the ones associated with the atrioventricular septal defect. They said sometimes it could be associated with other lesions, that sometimes it could be seen in the post-op of atrioventricular septal defects, that it was left like a double orifice valve.
Yes, but it's not the true defect. It's required.
Different.
Yeah, I don't know.
Completely
I would not
include those in the statistics. All right. Okay, so this is what they mentioned about epidemiology, and I think that again the most important thing that we see in the literature is that many of these children will be asymptomatic, and symptoms may appear if the valve then becomes stenotic or regurgitant, or sometimes the symptoms will be from some associated lesions rather than from the primary valve. And I wondered about this in adults. I mean, as I said, in pediatrics, we rarely see those, but do you recall, I mean, these patients that you mentioned, for instance, that you showed the pathology cases, were these patients that came in with clinical presentation because of these valves, because of the valves becoming stenotic or regurgitant? I wish I had someone here from adult cardiology to tell me more about this, because I think in pediatrics we really don't see much of this. Fernando, perhaps you could get into this and tell us if you've been called to repair this lesion in a child or adult at some point.
First of all, I'd like to thank you again to be taking part in very important. But this situation, this presentation is a real challenge to how to deal with these small kids with this kind of congenital defect. I have seen very rarely. I've seen quite recent one case that, but the case was not because of this double orifice mitral valve. In reality, the child had a malformation of the pupillar muscles, and then that's one question that I would make to Vera Aiello Ho, if this kind of presentation could come with some anomalies of the muscular pupillar muscle, like in aid or in a parachute pupillar muscle effects, and then could then have this kind of presentation. The last one I did operate, I tried to fix the valve, but at the end I couldn't separate this this bridge between the leaflets. Otherwise, the mitral valve would stay completely incompetent.
Let me ask you, Fernando. Do you believe it's necessary, or I think in most of the cases, since there is no dysfunction, it should not be necessary to section the bridge, I would say. I don't know. In the rare cases, when I showed the very stenotic one, maybe you have to open it.
No, I agree. I tried to fix the mitral valve because I repaired the incompetence of the valves, but at the end, in the post-op, there was still a gradient between the left atrium and the left ventricle, so it was still stenotic. And then we tried and we kept the patient on follow-up, but with otherwise, it's a very small kid. I mean, I couldn't replace the valve because of the child was very, very small. In reality, I haven't seen this kind of presentations. I haven't seen. I don't know how many cases you see. If you see Sandra doing echoes and as an isolated defect, as an perhaps you are seeing in some patients with these complex hypoplastic left hearts or those, I don't know what's.
I think they're very rare, Fernando, in general. I mean, it is, as you say, when the Boston study that would say 1%, as Yen mentioned, I think was including atrioventricular septal defects with double orifice valve. So isolated double orifice valve with or without left-sided lesions in association, I think, are very, very rare. Don't know whether we keep a very good eye into those, but generally when you do a short access of the mitral valve.
Yeah, but one point that it is very up to date now is we in cardiac surgery we also are promoting kind of defects when you do a mitral valve repair, a plasty, and at the end the mitral valve is a little bit incompetence at this stage, and there is a prolapse and incompetence at the level of between A2 and P2, as Yen Ho showed, and then we promote this a stitch, and it is called, it's very popular, the stitch now, and it's been replicated now by this intervention, the mitral clip procedure. Now we are doing this kind of a lot of procedures now, and I think the point is how is if the child of the kid is symptomatic or not, and then perhaps most of them, sometimes it's a finding, an echo findings, and the patient keeps well, but I haven't.
Yes, I wonder whether the management in cases of, like, say, severe valve regurgitation, probably a technical way of repairing it when there is a double orifice or something, there may be a little different, or the way you look into that. But very honestly, I had a quick look at some of the literature, but most of what I found was very limited data and just sort of isolated cases here and there, but no big series or anything like this. I don't know whether, again, Yen, Vera.
Well, you know, at the Heart Institute, I also perform necropsies in adults with no congenital heart disease, and they are supposed to have structurally normal hearts, just heart disease or valvular. But for those with no valvular disease, I would say that I found twice an adult with a double orifice, but very peripheral at very near the commissure, at the posterior septal commissure, and also peripheral within the anterior leaflet, with probably no symptom or no dysfunction at all. So it was, I don't have the photos, but it shows a very minor abnormality.
Yeah, do you get?
I agree entirely with what Vera is saying. And most of the reports in the literature are saying that they're usually symptomless. They don't produce much problems in childhood anyway.
It's very good, but still something to keep an eye, as we know that as any other valve, the potential for developing stenosis or regurgitation does seem to be more frequent in the few cases that they mentioned. They say that they can evolve into having particularly, I think, regurgitation at medium to long-term prognosis. But actually, the literature also says that there are no big studies on prognosis because the cases are rare and far apart. I think it was very interesting. A child comes in to do diagnosis of AVSD, and then you pick up on the echo, you get that image. And so I thank Dr. Rigby for sharing that with us. As I said in the beginning, I'm sorry he's not here to comment and to discuss, but we'll have a meeting with him in 3 weeks' time, which perhaps Ian could take part as well, because we will do it locally, and perhaps we can sit there, Ian. I will be visiting, and we've organized to do the Echoflix from the first week in July. We'll be doing from the Brompton over here, and that'll be very nice to choose a case that we can discuss together. Fernando, I think you're saying something?
No, I just wondering, as you said, that it can be seen after correction of the AVSD, just to, if there are some surgeons just watching us now, one of the ways of sometimes, if there is a complex AVSD, to fix the left AV valve, one of the alternatives to fix the residual mitral regurgitation is just to make what we have just commenting about. Some of the cases, it's very useful to put just a little stitch in the middle of the AV valve, left AV valve, connecting A2, A2, just to abolish the mitral valve incompetence, residual mitral valve incompetence. It was a very good case just to discuss, to comment about this.
To remember some things that old pediatric cardiologists and surgeons said. You create a disease to correct the other. And that, I think there's a story about Blalock housing and tetralogy of Fallot and Helen Taussig and all this, and saying you're proposing that you create a disease to correct another. Isn't that something to do with the history of the Blalock Taussig? And so Fernando is now doing this. He's proposing that he creates a double orifice mitral valve in order to decrease the mitral regurgitation. Wasn't that the proposal?
Yeah. Well,
yes.
In reality, that's what is modern medicine doing a lot.
Sure, absolutely. And you see, we may not have people now because Luciana just couldn't join, and Vitor, who is not in the surgical group but joins us a lot. He is the fellows are finishing their day-to-day. He just sent me a list of the Van Prague Award of the fellows who were finishing today, and that's why they're not here. But what we are noticing is that we get lots of comments after the session. Sometimes it's difficult in the middle of the day to be here, but I will challenge the surgeons that may be seeing this later, and clinicians as well, to discuss a little bit about ways of managing the atrial valve during the operation to decrease the regurgitation of the valve by creating a double orifice mitral valve. Did I understand it correct?
Yeah.
Good. Well, that's very good. What do the morphologists think? Can we do that?
I'd like to ask you, Sandra. You were the echocardiologist in charge here. Do you think it is easy to miss this lesion in a common echo, or how Dr. Rigby recognized it? They were very big, or concentric, or all the same dimension. And what can you tell us about this?
I think perhaps, Vera, in a native valve, when you're doing a good short axis view of a native valve, it's probably easier to identify that there are two orifices. It's something that you don't expect to be seeing there. You expect the movement of the opening of the mitral valve to have a very standard pattern. And if you're looking at it's a native valve, I think it probably is easier. Not know how easy. When Max showed those pictures, I think they're very easy in the way he shows, but obviously they're beautiful pictures, very nicely done. And I don't know whether doing an echo on a routine thing, on a routine exam, whether it would be that easy. But looking at the pictures of a normal mitral valve in short axis, I think a native valve would probably not be very, very difficult. Now, perhaps looking at Dr. Morai's post-operative AV septal defect valves, I will start looking more carefully into those to see if we can identify this created double orifice mitral valve. Because yes, we sometimes see the regurgitant jets in the left valve, and sometimes we see too little jets in the regurgitant valve. But I don't know whether it's because the dealing with the valve that obviously gets a lot of brightness in the exam and all these, that sometimes in the short axis it's not very easy to, or at least perhaps I haven't identified it very clearly as a double orifice valve. But I certainly will be looking more carefully in the postoperative group as well as in the native valves. I think in the native valve it's not very difficult to identify if you have a double orifice. But I'll look into audio echoes now very carefully to see the post-op double orifice. Okay. Well, I wonder whether you have any more comments about this. Not really? Okay, well, I must thank you all very much. And all of you, Fernando, who's been always with us, Sarah, that has been around also a lot, but it's actually her first day at the Echoflix. It took you coming to the Echoflix for us to get Dr. Aiello here at the end. She's been very busy, and we've been trying to get her to take part on our meetings. In fact, it's wonderful when we have a morphologist with us. I don't think anyone can stress enough the importance of a morphologist when we show an echo image or when we show a surgical image. And I have been challenging Fernando and other colleagues as well, who could bring us some images from the operating room, which would be so important to comment and all this. So it's great when we have not just the echo, but we have other images like magnetic resonance and CTs and all this, and certainly having the operating images and the morphology would be very important. The idea here is really to be able to chat with colleagues, to exchange ideas, and in a sense, to alert people who are dealing with these children. We're doing echoes, we're dealing with them clinically. I mean, this particular lesion that we're talking today was a lesion that's not clinically, in the majority of cases, it's not very significant, it's rare, and it may not have that impact to the majority of children, but we have been also discussing cases that, if missed to diagnosis, that if missed, have a tremendous importance to the follow-up and to the operation technique, the surgical technique, and all this. So it's really very important. And with that, I will send to you to say your final words, but keep the invitation for all of you, Vera, and to you too, Yen. It's so good. It's 4 o'clock to you, isn't it? About 4:30, nearly there. But every Friday at 4:30, we're here chatting about something. So we would love to have you also in future sessions. Okay? Shall I send then to Yen and then Vera and then Fernando to say your final words, Yen? Microphone.
It's really my pleasure to join you all. It's so nice to see your faces again, albeit remotely. So I'll see you soon in person, Sandra.
Fantastic. Lovely. And thank
Vera, when you next come. Fernando too, of course.
So, Sandra, thank you again. It was great to be here with Dr. Ho, Yen, and Fernando. And I hope we can meet personally sometime soon.
Yes. Thank you to Sandra for the opportunity. It was really a very challenging case, this one. And it was a great pleasure to share this time with these two prominents in the cardiac morphology in the world. Thank you very much. It was a real privilege to be here with you.
Wonderful. Well, thank you very much. And then we'll see you all next Friday, if we can. See you. Bye-bye.
Bye-bye. Bye-bye.